Okay, this is chapter 14, part 2. So continuing with a lot of the terminology. These terms are dealing with severity or duration of disease. And again, we've looked at most of these terms in the past, or you may also already be familiar with a lot of these terms. But we did in the virus chapter kind of look at acute, chronic, latent. So acute is when symptoms develop rapidly and the disease lasts only a short time. This is like your common cold, your flu. Those are acute illness. Chronic, on the other hand, is where symptoms develop slowly and tend to last possibly the rest of your life until that disease may actually cause death. That would be things like hepatitis B, hepatitis C. Subacute is obviously just between acute and chronic. Latent, we talked about in the virus chapter. That's when a disease is in your body but does not produce symptoms. It goes inactive or dormant or latent, and then it can periodically reactivate and produce symptoms. Herd immunity refers to immunity in most of a population. Probably everyone's familiar with this term now because there's a lot of talk of this term with COVID, right? The idea that if the majority of the population gets an infection or gets vaccinated against an infection, it can protect those who have not gotten the infection or have not gotten the vaccination. So herd immunity really is the goal for our vaccination programs. If we can get a good percent of a population vaccinated, we can protect the rest of those who may be too young or too old or have other underlying health conditions and not be able to get vaccinated, or those who are opposed to vaccination. So here's a question dealing with some of those terms that we talked about a little while ago in the part 1 recording. Some more terms here dealing with the extent of host involvement. A local infection means it's just in one area, so like a boil, an abscess, something like that would be a local infection. Systemic or generalized infection is either, it could be like a blood infection like throughout your body, or it could just refer to an infection deeper in your body. Like the fungal infections that affect the lungs, even though it's mainly in the lungs, we still call it a systemic infection. Because really, once something's in your lungs, it pretty easily can spread throughout your body anyhow. A focal infection is a systemic infection that began as a local infection. And the most common example, not the only example, but most common example of this would be like if someone has an abscess tooth, which would be a local infection, the bacteria escape from that abscess tooth and get into the bloodstream and cause a systemic infection. Sepsis refers to a toxic inflammatory condition arising from spread of microbes, especially bacteria and their toxins, from a focus of infection. So we'll talk about bacterial toxins in the next chapter, in chapter 15. And there we'll see like endotoxic shock and how bacterial toxins can very much lead to shock, which is linked to the sepsis. Bacteremia just refers to presence of bacteria in the blood, not multiplication. If the bacteria is actually multiplying in the blood, growing in the blood, then that's called septicemia. That's also known as blood poisoning. Toxemia refers to toxins in the blood. Don't get this confused with toxemia that can happen to pregnant women. That's a completely different condition dealing with blood pressure and stuff. This is actually bacterial toxins in the blood. Viremia is viruses in the blood. Primary infection just means an acute first infection, an initial illness that sometimes people get secondary infections. So a secondary infection is usually, subsequent to a primary infection, and often it can be with an opportunistic microbe, including sometimes people's own normal microbiota. So a good example of a primary, secondary that we often see, especially in elderly patients, is that an elderly person may get a common cold or a flu as a primary infection. And then because their immune system has been weakened, their respiratory system has been damaged by that primary predisposing infection, now the person's own Streptococcus pneumoniae, because a good amount of us carry Streptococcus pneumoniae as normal microbiota in our nose throat area, now that strep pneumoniae can actually cause a secondary infection, lead to pneumonia, and I've got to sneeze. Excuse me. In elderly persons, especially once they get that Streptococcus pneumoniae as a secondary infection in their respiratory tract, the bacteria can also then spread to the blood-brain barrier and lead to meningitis. And so that is a very serious secondary infection that unfortunately can be very deadly for elderly persons. And it's from their own normal microbiota, but because there was a primary infection that kind of led to that whole cascade of events. Subclinical disease is when someone has infection, but they have no noticeable signs or symptoms. A lot of this has been called asymptomatic as well, right? Again, with COVID, there's been a lot of talk about that, about people who don't have any symptoms, but they can be a source of infection. So it can be cases like that where people they have the infection, but their immune system is not doing, there's no response, there's no signs or symptoms, but they can be a source of infection for others. This can also be the case in latent infections like herpes infections, where the person has no signs or symptoms, but again, they can be spreading to others. Also, some chronic conditions like hepatitis B, hepatitis C, where, the first 10, 20 years, there may be no symptoms going on. But again, the person can be infecting others. We do call people who are a source of infection for others with asymptomatic or subclinical or inapparent infections, they're called carriers, right? They are carriers. They're a source of infection for others. So why do some people get the infection and other people do not get it at all, or may get it in an asymptomatic fashion? Well, there are different predisposing factors that make some people more susceptible to disease than others. Believe it or not, gender does play a role for certain types of infections. For example, females are way more likely to get urinary tract infections than males due to the anatomy. Males are actually more likely to get respiratory infections more than females. Different reasonings for that, but some as silly as, men breathe deeper than women, but also men work in more occupations where they may be more exposed to, soil and dirt and things being stirred up, like construction and farming and firefighting, and so lots of different reasons there for gender. Inherited traits such as sickle cell gene, which can actually protect from malaria, but again, if you have sickle cell disease, it's worse because those individuals will be more predisposed to other infections just due to the immune system being affected. Climate and weather. So yes, colds and flu are more common in winter months due to the virus surviving better usually in cold weather. And also people kind of clustering together more sometimes in cold weather, maybe not so much in California, but definitely in other parts of the world where it's very, very cold, like in Minnesota, and they actually in Chicago and stuff, where then they have like indoor sidewalks and things, and so more people in close proximity, more spread, right? Lack of vaccination, fatigue, age, of course, very young, very old are more susceptible. Lifestyle, right? Taking care of yourself, nutrition and lifestyle, getting enough sleep, not being under extreme amounts of stress, not having poor nutrition, because we know all those things can make you more susceptible to getting infections as well. And then chemotherapy, again, remember this doesn't just mean cancer treatment. This means medication, being on any kind of medication that may be inhibiting your immune system. So development of disease, these are the stages that pretty much any infectious disease will go through, but the interval, the time period, can really vary. So we'll see on the graph that there is actually not an exact time scale, because this, depending on the disease, could be in the matter of a week, or it could be in the matter of 20 or 30 years, right? Depends. Is it acute infection? Is it a chronic infection? But they all kind of go through these phases regardless of that time scale. So incubation period is the interval between the initial infection and the first signs and symptoms. Then prodromal period is when those first early signs and symptoms start, but just very mild, like when you feel like you're coming down with something. You got that malaise. You're like, I'm tired, I feel worn down, my body hurts, I have a headache. Just some early stuff, right? Maybe a little itch in your throat or something. And then period of illness. That's when the disease is most severe. Then your period of decline, signs and symptoms subside, and then period of convalescence as the body starts to be able to get back to its pre-disease state. So we can graph this as number of microbes in the body over time. But again, there's not any indication of days, weeks, months, etc. here, because it can be on the scale of days, or it could be on the scale of many, many years, just depending. But you could see that regardless, in the incubation period, there's not a lot of microbes in the body just yet, and that's why there's no signs or symptoms just yet. But as the microbes start to increase, that's when you have the prodromal period. When microbes are at their peak, that's when you have the period of illness with the most severe signs and symptoms. And then as the microbes start to decline in the body, that's when your signs and symptoms start to decline. And then finally, when the microbes will go away, that's when you have the period of convalescence. So here's a question about the incubation period for a cold is 3 days, and the period of illness is usually 5 days. If the person next to you has a cold, when will you know whether you contracted it? So we'll put this into a multiple choice for you. So reservoirs of infection. So we know for sure humans are obviously reservoirs, right? We know we carry a lot of infections that we can get from each other. And we talked about how carriers can be people who have interparent or latent infections, and they could still be spreading to others. But animals can also be reservoirs of infection. We can get things like ringworm, rabies, oh my gosh, I'm just drawing a blank. Tapeworms, right? You can get different things from animal reservoirs. Diseases that we can get from animals are called zoonoses or zoonotic diseases. And then, like I was mentioning when we talked about non-communicable diseases, you can also have non-living reservoirs such as soil and water, where we can pick up an infection from soil or water. Wow, this looks really small, even on my screen, but this is in your textbook as well, if you want to refer to this. It's not anything I would test you for this exam, but if you're interested, you can see this list of selected zoonoses: viral, bacterial, fungal, protozoan, and helminthic. So lots of very common diseases that are zoonotic that we can get from an animal reservoir. So transmission of disease. So we all know that we can definitely get disease from contact, right, with others who are infected. And that can include direct contact, where there's like skin-to-skin contact. This could be kissing, holding hands, or of course, sexually transmitted would fall under direct contact. Congenital transmission is from mother to fetus or newborn, so diseases that either cross the placenta or are given to the baby during birth. Indirect contact transmission are diseases that are spread to a host by a non-living object called a fomite. Again, I think most people know about this now, especially with COVID. It's kind of been a living case study situation that we've all been thrown into, where we've probably learned, a bit about disease that maybe you didn't know before. But a fomite can be a doorknob, a drinking glass, a tissue, a towel, piece of gym equipment. Possibly, I don't know. I hope no one's gotten COVID from like Amazon packages, but I know there was a whole lot of talk about COVID surviving on cardboard, and they did have some outbreaks associated, in Amazon distribution centers. They had some infections, and so I know at home we were spraying all of our Amazon packages with Lysol. But any of those things could be a fomite, some kind of non-living object that may harbor a disease, a pathogen, and then you touch that object, and then you touch your face, or you eat without washing your hands or something like that. Droplet transmission. This is probably what more commonly is happening with COVID, and why, face masks are a good idea, because every time we talk, let alone sneeze or cough or laugh or yell, droplets fly out of our mouths, right? And they fly through the air. And they can be carrying pathogens that then the next person can breathe in. So this droplet transmission is defined as less than 1 meter, which is, I'm trying to remember how tall a meter stick is now. It's greater than 3 feet, I think, right? It's something like that, but it's less than 6 feet. I know that because I can hold a meter stick up to me, and it's about 3 to 4 feet if I remember. Refresh on my math. So, vehicle transmission. This is transmission by an inanimate reservoir, which would be airborne, waterborne, or foodborne. So, what's the difference, though, between this droplet transmission of airborne droplets and this airborne over here? Well, basically, that's why they define this as less than 1 meter for droplet transmission. So that's really like more directly coming from somebody, being in proximity of somebody coughing, sneezing, talking, etc. Versus here, it's longer distance. It's greater than 1 meter. It's where the pathogen could be getting carried on dust particles and through the air itself, and not directly from contact with somebody's airborne droplets. And then, of course, we know vectors can transmit disease. We talked about this before. So arthropods like fleas, ticks, mosquitoes, because they take blood meals, they are usually transmitting diseases through that blood meal. But we also know that pathogens that don't take blood meals, like flies, can do mechanical transmission, where they're just carrying the pathogen on their feet. And then most of the pathogens that do blood meals are usually doing biological transmission, where the pathogen may have some part of their life cycle in the vector. And even sometimes, like with Chagas disease, it doesn't have to be transmitted by the blood itself. It could be transmitted in the feces of the animal when they bite you or take a blood meal. So here's a table giving you some representative arthropod vectors and the diseases they transmit. Again, this is informational. I will not test you on this on the exam.
Infectious diseases are transmitted from either a host's portal of exit or a reservoir to a new host. There are 3 major categories of transmission: contact transmission, vehicle transmission, and vector transmission. Contact transmission is the spread of pathogens by direct contact, indirect contact, or droplets. Direct contact can include touching, kissing, or sexual intercourse. It can also include transfer from mother to fetus, and contact within a single individual, such as between the nose and the eye. Droplet transmission occurs via mucus droplets within a distance of less than 1 meter. This can occur while exhaling, speaking, coughing, or sneezing. Indirect contact involves spreading of pathogens by inanimate objects called fomites. Fomites can include needles, eating utensils, money, tissues, toys, and medical equipment. The second major category of transmission is by vehicle. Vehicles can be air, water, and food, as well as bodily fluids such as blood that are handled outside of the body. Airborne transmission involves the spread of pathogens via an aerosol. This aerosol can be either dust or droplets traveling farther than 1 meter. Waterborne transmission is a major mode of transmission for many gastrointestinal diseases such as cholera. This usually occurs when fecal material enters the water supply. Foodborne transmission is also typical of many gastrointestinal diseases. The pathogens may enter the body in food that is improperly prepared or contaminated with fecal material. Vectors are arthropods that transmit diseases from one host to another. The term vector is most often used to describe insects or arachnids that are part of the pathogen's life cycle. For instance, the mosquito in malaria or the flea in bubonic plague. However, some insects can also passively carry pathogens with their bodies. For instance, a fly may carry typhoid or dysentery from a host species to the food of another person.
All right, and here's a question, or 3 questions I will have to convert over. Okay, one of the last topics in this chapter is healthcare associated infections, or HAIs, which previously were known as nosocomial infections. These are infections that are acquired while in a healthcare facility of some sort. Could even be outpatient, does not have to be a hospital, but some kind of healthcare facility. These affect 1 in 25 hospital patients. 2 million people are infected per year, and over 70,000 people die.
Nosocomial infections are those infections acquired by patients while they're in a healthcare setting. It's estimated that 30% of nosocomial infections are preventable through more stringent use of aseptic technique by healthcare personnel. There are 5 major categories of nosocomial infections. The most common type of nosocomial infection is a urinary tract infection. These are typically contracted during insertion or removal of urinary catheters, and usually involve the normal flora of the patient or healthcare worker. The second most common type of nosocomial infection is a surgical wound infection, again caused by normal skin flora that get into the surgical wound. Lower respiratory infections are usually associated with respiratory devices. Cutaneous infections commonly occur in newborns and burn patients. Bacteremias are another type of nosocomial infection, usually due to intravenous catheterizations or injections. All other infection types account for about 11% of all nosocomial infections. Patients are susceptible to nosocomial infections because their immune systems are already weakened. The stress of surgery on the body also makes it harder to mount an adequate defense against these microbes. The exposure of the compromised patient to antibiotics, whether as treatments or as aerosols in the environment, allows resistant microbes to become abundant and cause disease. Healthcare personnel are often carriers of resistant microbes. The need for invasive procedures such as injections, insertion of catheters, or surgery increases the chance that microbes from the skin can enter the bloodstream. And finally, the constant movement of staff and visitors among the patients increases the chance that microorganisms can be passed from one person to another.
All right, so that video was really good about going over the factors involved in nosocomial or HAIs. Microbes are in the hospital environment because they're everywhere, right? They're on the patient, they're on the medical provider, they're just in the environment. They talked about how obviously the host, the person in the hospital, is sick. Maybe they had surgery, whatever it is, they're probably immune compromised because of that. And then that chain of transmission in the hospital, that it could be from the patient themselves, other patients, visitors, healthcare workers. And the chain of transmission is really the only thing we can try to control. We cannot very well control the other two. I mean, obviously, having a clean hospital environment, but again, you can't get rid of all of the bacteria because they're on the patient, they're on everybody. A compromised host is defined as an individual whose resistance to an infection is impaired by disease, therapy, or burns. And so again, the result of these three overlapping factors can result in an HAI. And again, our main focus is to try to get rid of this chain of transmission as much as possible. And that's why aseptic technique is so important when it comes to any kind of catheterization, any kind of medical surgical procedures. Cleanliness in the hospital setting, of course, sometimes restricting visitors and things like that as well. So just like the animation showed, you do have the breakdown of the different types of infections here. This is not details that I would test you on, but you can see actually that C. diff falls here. It's third most common, I guess now. Still, lower respiratory infections, especially associated with respiratory devices, ventilators, respirators, as a major cause. A lot of pneumonias. There, surgical site infections with things like MRSA is also big here. And then, as was mentioned, UTIs because of catheters are fairly common as well. So again, informational in this table, not something I would test you on, but you can actually see some of the common causes, the different bacteria that are common causes of HAIs in this table. So again, universal precautions, standard precautions are very important when trying to prevent and control HAIs. Hand washing, PPE, etc. We don't really need to get into all the details of that, but I think most of us know this kind of stuff already.
Nosocomial infections cause thousands of deaths and cost the healthcare industry millions of dollars each year. This can be avoided if healthcare personnel and patients know and practice the proper precautions. One study showed that hospital personnel only wash their hands 40% of the time before interacting with patients. The first goal of a healthcare professional should always be the health of the patient. Proper and frequent hand washing by personnel is the most important method of preventing transmission of nosocomial infections. Healthcare workers should wash their hands thoroughly before and after interacting with patients. Proper disinfection and sterilization of equipment also helps to minimize nosocomial infections. Healthcare workers should wear personal protective equipment when appropriate. Catheters, intubation devices, and needles should be sterile, preferably single-use disposable devices, and should be inserted using aseptic technique. Contaminated material should be disposed of promptly and properly. Healthcare personnel should not come to work sick. Most importantly, all healthcare employees should receive periodic training in the proper precautions for infection control. Physicians should prescribe antibiotics only when necessary, and antibiotics should be rotated within a hospital setting so that resistance is minimized. Invasive procedures should be performed only when necessary and using aseptic technique. Immunosuppressive drugs should be used only when necessary, and extra precautions should be taken to minimize exposure of the patient to microorganisms. Patients can prevent nosocomial infections by following the directions of their healthcare professionals. If a patient notices a healthcare worker not following the suggested precautions, they should bring it to their attention. Proper cleaning and hand washing is important for patients also.
All right, all good advice, right? And again, most of us know it, but doesn't hurt to be reminded of those things, and unfortunately sometimes maybe to have to remind others in the healthcare fields. Emerging infectious diseases. So these are diseases that are new, increasing in incidence, or showing a potential to increase. A good amount of these are zoonotic. Again, we can definitely relate this to COVID and some of the others that have come out over recent years, like SARS and MERS and swine flu, right? So you can definitely see that a lot of them are coming from some kind of animal. A lot of them are viral in origin, all those I just named. And the only thing with the ones I just named, they were not vector borne, but we did have that as well with like West Nile. About, how long has it been now? 20 years since West Nile came to the United States. And it is viral, vector-borne, and zoonotic, so it fit into all those. So here's some examples of some emerging infectious diseases and the contributing factors. Now, I want you to know the contributing factors, but you do not have to memorize the examples, but the examples are just given, to help you understand the contributing factor. So genetic recombination is a contributing factor for emergence of certain infectious diseases, where we talked about the E. coli 0157, it gained the Shiga toxin from the Shigella bacteria. How did it gain that toxin? Well, from some type of horizontal gene transfer, right? Genetic recombination. It's very common with flu strains. That's how we get new strains of the flu, genetic recombination. Or you can have complete evolution of new strains. That's what happened with this Vibrio cholerae 0139. We can have antibiotic resistant strains like MRSA and VRSA and CRE and others. Changes in weather patterns. This happened with hantavirus in the 90s in the southwest United States. We had a very rainy season, and then followed by a warm spring, summer, and that promoted a lot of rodents, and then the rodents ended up moving into people's houses, got into their attics, into their ventilation systems, and rodents can carry hantavirus in their urine and feces, and then that was blown out, the virus was blown out through the air conditioning systems, especially on the Indian reservation in the southwest United States, the Navajo reservation. And there was an outbreak of hantavirus, but it really was all linked back to the weather patterns that led to the big boom of the rodent population. Modern transportation played a role in West Nile arriving to the continent of North America. Chikungunya as well has been moving up, as well as Zika. These have all been moving from tropical areas up into the rest of the world. Insect vectors can play a role as well in them spreading their areas, spreading into new areas, bringing new diseases with them. And of course, us spreading into new areas, expanding human settlement, as well as ecological disaster and war have all played roles in disease outbreaks as well, including right here in Southern California. After the Northridge earthquake, we saw more valley fever. This is the kind of scientific name for valley fever, coccidioides mycosis. So after the Northridge quake, there was a lot of things that had to be torn down and rebuilt, and all that stirring up of soil and the construction actually led to more cases of valley fever. Animal control measures, the more deer there are, the higher the deer population, the more Lyme disease we see. And lastly, public health failure. So in the Soviet Union in the 90s, they just decided, oh, we don't need to do booster shots for diphtheria anymore. Everyone's fine. That disease isn't around anymore. Guess what? Then they had a huge outbreak of diphtheria. And then lastly, bioterrorism, like in the case of anthrax after September 11th. The last part of this chapter is on epidemiology. It's actually, the main topic of this chapter, and I do want you to know the definition of epidemiology, which is the study of where and when diseases occur and how they're transmitted. But I do not require you to know the different types of epidemiology or the different epidemiologists that are covered, okay, which is here. So you do not need to know these. But I did tell you at the beginning of this chapter about the cover slide and about John Snow was the epidemiologist who was able to map the occurrence of cholera in London. We talked about Semmelweis before. He was the one that advocated hand washing to decrease the incidence of puerperal sepsis, also known as childbirth fever. We never talked about Florence Nightingale, but this was a nurse who showed that improved sanitation decreased the incidence of epidemic typhus. Again, epidemiological data is very nicely expressed into graphs. So you can see this here. They're showing cases of Lyme disease from 1999 to 2016. Here, they're showing it by month. In the year 2016, you can see obviously there's certain months where it is more common, usually in those summer months. Here you could see tuberculosis, 1945 to 2015. Here is those 3 examples of the different types of epidemiology. Again, I'm not going to test you on this though. And then the last thing I want to tell you in this chapter is about the MMWRs. So our discussion board, our next discussion board that's due probably in a week or 2 from now, is on the MMWR, morbidity and mortality weekly reports that are put out by the CDC. So the link will be provided in the discussion board. You'll go find an interesting article related to microbiology in the MMWRs, because they're not all related to microbiology. You can find some on smoking and breast cancer and other things. I'm sure there's a lot on COVID in there currently, but you could find other topics as well and do the discussion board on your topic. And here's some terms that go along with that if you need to refer to them to know what morbidity and mortality, or morbidity rate and mortality rate, notifiable infectious diseases. You have those definitions there. This is actually the list of notifiable infectious diseases put out in 2017. I imagine there's probably a newer one since then. But basically, if somebody comes into a hospital, doctor's office, etc., and is diagnosed with one of these diseases, that medical agency is required by law to notify the public health agencies. The local, state, federal agencies would need to be notified.